Hello, and thank you for joining me today on Sleep Medicine Topics. My name is Dr. Kevin Smith, and I'm a clinical psychologist specializing in behavioral sleep medicine. I'm also the psychologist for the Sleep Disorder Center at Children's Mercy Hospital in Kansas City, Missouri. And I'm joined today by my colleague and friend at the Sleep Disorder Center, Dr. David Ingram. He is a physician who is board certified in sleep medicine. Dave, thank you for joining me today.
Yeah, my pleasure, Kevin.
So this is the first of what I hope to be a series of podcasts focusing on some of the more common sleep problems that people are experiencing. The idea behind this really came out of my observations of many of my colleagues, friends, and family who are struggling with sleep these days more than ever with all the things that are going on in the world. So I thought it would be useful to review the symptoms, causes, and treatments for some of the more common sleep disorders. And you don't need a background in sleep to benefit from this podcast. It's really meant for anyone who has questions about sleep. And in fact, my goals of the series is just to also be informative but interesting as well. So I think you can have a little bit of fun when you're learning. So we'll see how that goes. Sound good to you, Dave?
That sounds great. Yep.
All right. A quick disclaimer before we start. The opinions expressed today do not represent any other entity and are solely our own opinions. And of course, before considering making any changes that could affect your sleep or physical or mental health in any way, you want to consult a physician. The information presented today is general and therefore it might not be specific to you, and it does not constitute medical advice. So, the focus of the podcast today is going to be on medical sleep issues. And in the future, we might do topics such as insomnia. That could cover a couple podcasts. But Dave and I talked before we started, and the two that we're going to focus on today are probably the two, Dave, would you say the most common that you see?
Absolutely.
Yeah. Restless leg syndrome and sleep apnea. So let's start with restless leg syndrome, and I can already tell that's going to be a mouthful, so I plan on using the acronym RLS, which it's popularly known that way. So Dave, could you start us off by just giving us a general overview of what restless leg syndrome or RLS is?
Sure, yeah. The first thing about restless leg or RLS is that it does have different names. And if you think restless leg syndrome is a mouthful, a couple of years ago there was kind of a push to actually put a new label on it because I guess restless leg didn't sound serious enough. So they now another name for it is also Willis-Ekbom disease. And so that it emphasizes the fact that it's a disease. But in any case, whatever name or label you put on it.
I did read that. Sorry to interrupt. I think, and maybe you'll be talking about this today, but I think the concern was that the name doesn't make it sound official, like restless leg, and then adding on a syndrome, like itchy nose syndrome or something like that, where we know it's a real thing, but the name itself, I've heard people say, is that a real thing?
Right.
Have you heard that?
Yeah, like that name didn't kind of reflect how just bothersome this can be and how much it can affect people in their daily lives. So yeah, exactly right. And the disease, I think, was meant to, putting that label on it, I think was meant to emphasize that this is a real thing. And it's important for people to think about and consider and get treated.
And do we want a little trivia on that name real quick? Why not? Okay, I have that. You're like,
go ahead. Yeah.
British physician Sir Thomas Willis first noticed the ailment during his studies of the human nervous system. So that's the Willis part. And then Swedish neurologist Dr. Carl Axel Ekbom named the condition restless leg syndrome. So that's how they came up, right, with the Willis-Ekbom name. That is harder to say, you're right, than restless leg syndrome, but that's okay.
And it is actually really fascinating to go back and read their initial descriptions of the disease, because it really nails home what people experience and the words that they still use today. So, but in any case, to answer your original question, restless leg or Willis-Ekbom, basically, this is a sleep disorder where you get these weird, strange, bothersome sensations in your legs at night, and you may have this feeling like you have to move your legs. You lay down, you're trying to do everything right. You need your 8 hours or whatever to function at your best, and golly, you just can't fall asleep because your legs are driving you nuts. And people use different words to kind of describe what that feels like, but just an uncomfortable sensation, a having to move sensation in the leg is the most common symptom that people kind of report or experience with it.
So when you say uncomfortable, that's what I hear too. What I don't hear a lot, and maybe it's a way to help people differentiate, is significant pain. Would you agree that if it's restless leg syndrome, it probably isn't painful, it's just more annoying and uncomfortable. Is that fair to say?
Yeah, exactly. Yes. They're going to be using words like, or they may be feeling like a creepy, crawly feeling in their legs, maybe a pulling feeling or like an itching. It's usually a deeper kind of feeling. It's usually in both legs rather than one. And it's usually not like on the surface of a skin kind of a feeling. It's usually deeper, and it's usually below the knees in the legs. So that's usually the description that they're going to be providing me, rather than just a pain. If it's a pain, or if they're describing more like a cramp, that can be something else. So, for example, some people do get nighttime leg cramps, like the Charlie horses in your calves and call it. That's also extremely bothersome, but it's not restless leg. It's a different entity altogether.
Now, I don't know if you personally have ever experienced RLS symptoms. I think I have, and it is bizarre because it really feels like it's coming from inside your legs, and you're driven to move them, and then when you do, it stops. And the reason why I asked about pain is I was at a conference many, many years ago where one of the pharmaceutical companies who makes a medication to treat RLS had this display where you sat in this chair and you stuck your legs in these tubes. Did you ever see this? Is this something familiar to you?
This is a new one to me.
Oh, yeah. Okay. So you put your legs in these tubes, and then there are LED lights on the outside, and then they flip a button, and it's supposed to simulate what RLS feels like.
Oh.
Yeah, so to me, it simulated about 25 people pinching me really hard in different areas of my legs. And then the lights were supposed to correspond to where the feeling was. And I was, it was painful as an overstatement, but it certainly wasn't, it didn't feel good, that's for sure. And I wanted it to end quickly.
No.
And so to me, it did not feel like what I think restless leg feels like, to the point where I thought maybe this was some sort of experiment and I was being videotaped. I don't know, but I think they missed the mark. We did get a cookie after, so that's nice.
Oh, that makes it better. So what did you experience then that felt different than that?
You mean personal?
Personally.
Yeah. So to me, when I get it occasionally, to me, it is this drive to move your legs, and it seems to come from inside of the leg. So it's not like on the skin. It's not like itchy in that way. I can see why people struggle to describe it. It doesn't hurt. It's just, kind of this annoying feeling that you need to maybe like stretch your legs, and then you move them and stretch them, and it'll go away for a second, and then you stop, and then you feel like you have to do it again. So, yeah, it is a bizarre feeling, and I do understand why people struggle, describing it. But I just wanted to see if, I was right in thinking that pain really doesn't seem to be one of the major symptoms.
Exactly. That's a perfect description.
Right. So what causes restless leg syndrome?
Yeah, that's a great question. So a lot of times it kind of runs in families. And so we think that there's maybe some genetic component to it. Other times it just kind of seems to be out of the blue. Sometimes it can be related to other medical problems a person may have. So, one thing that we're usually thinking about is there an iron deficiency going on? Iron is important for the production of dopamine in the brain, and dopamine is involved in moving and sensation, and so maybe that's playing a role in it. So that's usually something we're checking in our patients with restless leg. And other medical problems that can also cause it would be any kidney problems, diabetes, some other neurological problems as well. And then finally, it's really common in pregnancy. Oh my goodness. It's a very uncomfortable thing that happens during pregnancy pretty commonly, and it can be challenging to treat as well. But usually where we're starting is looking for any kind of iron deficiency as something to treat and potentially make it better.
And so that would be a pretty straightforward therapy of just taking an iron pill. Is that what you would recommend, or is it intravenous or?
Oh, yeah. So usually I'll start off with doing oral iron. Iron can be given either by mouth or through an IV. The advantage of doing it by mouth is you don't have to go to the infusion center and have an IV hooked up and kind of go through that. The advantage of doing it through the IV is you can kind of get a big slug of iron all at once and not have to do a daily medicine then for it. But almost all of my patients I have on oral iron who need it, and it's usually pretty well tolerated. There's some side effects that we kind of have to deal with sometimes. Iron can make you constipated. There's certain things that we always try to talk about in terms of when you take the iron, you want to maybe have a little bit of vitamin C with it to help the absorption. So maybe with a glass of orange juice, or try not to take it at the same time as having dairy products, so like milk or yogurt or things like that, because the calcium in that can inhibit the absorption of it. So there's some things that go along with it, and then we also have to kind of reassess and recheck levels every 3 months, 6 months or so to make sure that we're making progress in our levels, but also more importantly, clinically, that the person's getting better with that therapy. So there's iron, there's stuff that goes along with it, but a lot of times it can be quite helpful.
And is this a common syndrome?
Yes. So in adults, maybe 5 to 10% of adults struggle with restless leg. In kids, less than that, but still maybe 2 or 3%. So it's really common. And it's something a lot of people struggle with. Absolutely.
And just back up a little bit. I think sometimes there's confusion between restless leg syndrome and then the movements that happen while we're asleep. So with restless legs, you're really talking about the feelings and the subsequent movements of your legs before you actually go to sleep.
Exactly. Right? Yeah. So restless leg it's a diagnosis based on what people tell us about what they're feeling. Okay. But we also have movements that happen when we're asleep. Some of us are really restless sleepers. We toss and turn. We kick our legs a lot. And some people don't have the restless leg syndrome symptoms, but they are very restless with a lot of leg movements during sleep that they may not actually remember. They just wake up in the morning and they feel like, man, I'm still really tired, but I got enough sleep, but I don't feel like I slept at all. What the heck happened there? And so sometimes there are people who have these leg movements during sleep that disrupt sleep quality and then result in those symptoms. And really the way that we get at looking at that is by doing a sleep study. So for restless leg, we don't need a sleep study to diagnose that. That's totally based on what someone tells us. If a person is not having restless leg symptoms, but is a very restless sleeper and feels unrefreshed or is having daytime symptoms, then we can do a sleep study and check for that leg movement disorder that may be there causing those symptoms. And the name of that leg movement disorder that we look for on a sleep study, it's called periodic leg movement disorder. All that means is that you have a lot of leg movements during sleep. Those leg movements tend to come in groups, so they're periodic. And it's a disorder because it disrupts your sleep quality and results in symptoms during the day. So periodic leg movement disorder, or PLMD. And sometimes people with restless leg can have those leg movements on their sleep study. Maybe 2/3 or 3/4 of people with restless leg will also have a lot of leg movements on their sleep study. But again, if they have the restless leg syndrome or Willis-Bottom disease, you don't need a sleep study to confirm the diagnosis. It's based completely on what they tell you.
And so for those movements at night, you just might be tired in the morning, even after a full night's sleep. That's one way to tell. Or you could have your bed partner glare at you while you're having your coffee in the morning because you kicked them all night. So I think there are other ways to find that out. All right. So why don't we talk about treatments? So first thing you said is that you look at is iron, and maybe that's where it stops. Maybe that is the key to someone's RLS. What are I know there are some behavioral based treatments, for some, such as massage, heat, cold, compresses, things along the warm bath, things like that for someone with mild, symptoms that they recommend. There are also some distraction techniques that I've read that also can be useful, but it seems like for the behavioral based treatments, it really is for people who are suffering maybe from mild symptoms. And if it gets more severe, those don't seem to be as effective.
Exactly. That some people, their symptoms are so infrequent or so mild that you can do some of those pretty basic things, and that's all you have to do. The other one that I would add in there is exercise. Having regular, moderate exercise can be very helpful for restless leg and in sleep in general. It can make a huge difference. So there's non-medicine things you can do. The other thing that I think about is, are there things that the person is doing or taking that could be making their restless leg worse? And are those things that we can change? So common things would be, if someone's having trouble sleeping or falling asleep at night, a lot of times, what are they going to do? They're going to go to their, drugstore and maybe get something over the counter, like an antihistamine medication that could make them drowsy because they think that's what they need to help them fall asleep at nights. But the problem is that antihistamine may be actually making their restless leg worse and exacerbating it. So that's one thing I always think about. Another is a lot of people are taking antidepressants because they have some trouble with mood or anxiety. That's great. That can be very helpful. But many of them can also exacerbate restless leg. And so that's something to keep in mind and look at and have a conversation with who's ever prescribing that medication. Hey, is there an alternative type of antidepressant or anti-anxiety type medication that might be effective for me but may not make my restless leg worse? So that would be something to think about. Other common things that people consume that aren't medications but are substances are caffeine, right? If you're having trouble sleeping and you're tired during the day, what are you going to be doing? You're going to be slamming caffeine all day to try to keep awake. But the problem is that can make your restless leg worse as well. And then finally, I don't mean to be a downer, but alcohol also makes your restless leg worse. So trying to limit or just stop consuming alcohol, that can also improve your restless leg quite a bit. And alcohol disrupts sleep in a major way otherwise, besides just restless leg. But some things to keep in mind there. So
would you add smoking into that?
Oh, yeah.
Mixture?
Yeah, absolutely. Yeah. Good point. Yeah. The nicotine and smoking and things. Absolutely.
So unfortunately, some things that people might go to actually, kind of indirectly manage the effects of restless legs. So they're tired. So they drink the caffeine. They're tired and they might be stressed. So smoking, and then alcohol for some people, it does disrupt sleep. It helps them to fall asleep though. And so people are understandably tired and then compensating by doing things that unfortunately can actually make it worse.
Exactly. Yes. So there's behavioral things we can do. There's things that we can try to avoid or modify in our lifestyle. And then if needed, there are medications that can be helpful for restless leg. We talked about iron a little bit, and that's usually where we try to start. So we'll check a level, and if needed, put the person on some supplemental iron, and sometimes that's all they need. But sometimes that's not effective, and we need to go to other medications. And there's a couple different types of medications then that we can use for restless leg. Some work through the dopamine system. So, for example, like pramipexole or ropinirole are really commonly used medications that work through our dopamine system in the brain and can help calm those sensations in the legs. The thing that we need to kind of watch out for with those medications, besides their regular side effects, is they can sometimes, over time, we kind of have to escalate the dose because they aren't as effective. And then sometimes they can actually worsen the restless leg symptoms with increasing doses. And we call that augmentation. And that can be a really tricky thing to manage. And sometimes we'll have to wean them off of those medicines and go to a totally different type of medicine. So that's kind of one big downside of those dopamine type of medications. There's another group of medications that are like gabapentin. There's a couple different versions of that that can be helpful for restless leg. And there's a few others. But usually iron, some dopamine supplement if needed, maybe a gabapentin type medication if needed are usually where we're starting. There's a few other options, but we do those less often.
Okay, so it sounds like medications can play an important role for some, but maybe a second step, first exploring some lifestyle changes and iron therapy as kind of initial path.
Exactly.
Okay.
Exactly. Yeah.
And then, closing out the medication discussion, of course, you would need to see a physician for that and get a prescription if that's the direction that you're going. There are alternative therapies out there that people can explore on their own for better or worse. We all have Google and, everybody, even doctors, look things up for themselves and there can be some good things out there and some bad. I was wondering if you could just talk about a few that you've heard, more popular ones that you think could be helpful and ones that, really need to be debunked.
Yeah, absolutely. So, for any alternative treatment, I always try to keep an open mind and kind of a willingness to try things. And I think patients appreciate that, and that's what they want. And so, there's some really nice things written about, the kind of approach to alternative therapies in general. One of our colleagues actually Anna Esparham, wrote a really nice article about integrative medicine. And kind of talking about balancing what do we know about the safety of a therapy versus what do we know about how well it works and this kind of a thing. And, we're at an academic institution and we always want to kind of be out on the leading edge of new therapies. But at the same time, we don't want to be out so far on that edge that we fall off the cliff, kind of a deal. So, some low risk strategies that I think would be really reasonable to do would be yoga. And acupuncture, is the evidence really strong that those are going to be super effective? Nah, but I would say those are pretty low risk things that would be reasonable to try, and I think can have other health benefits sometimes as well. There's a new device actually, so. It's like a vibratory device, provides stimulation to the legs, that actually had FDA approval in 2014. And this is a fairly active area of research that I'm intrigued by. I think it's really interesting because it's not a medication that has potential side effects of medication. It's passive, and works through the body's kind of, natural sensation, system and nervous system to be a completely new mode of therapy. So there's some vibratory devices that people are working on. One that I get asked about a lot, I get asked about every kind of supplement. Most of them we just don't know if they work or if they're safe or not. One common one would be magnesium. At this time, there's not a lot of evidence that that's really effective as a treatment for restless leg. Another one that I'm really intrigued by, though, is vitamin D. There are several studies now looking at vitamin D deficiency and the risk for restless leg and showing that relationship. And so now I think the next step in that research is, taking those people, supplementing with the vitamin D and seeing if their restless leg gets better or goes away. And I think people are working on that, and that's a promising avenue of research.
And so with a lot of the possible treatments that you listed, people can just purchase these. You can go to a large scale pharmacy or a department store and pick these up. And while the accessibility is good, you would recommend that someone talks to their doctor before trying any of those things, correct?
Yeah, of course. And specifically, for example, like if you talk about vitamin D, if I'm considering doing that with one of my patients, I'll check a level. And I mean, if their vitamin D is insufficient, then I'll consider vitamin D supplementation. If the vitamin D is already normal, then of course I won't do it. And so I think if you're thinking about a supplement, it may be worthwhile to talk with your provider about actually checking a level and seeing if you're already at an okay level already, and so that therapy wouldn't make sense for you, that kind of a thing. So, I think it would be a great idea to first talk with your doctor. You can do a lot of things over the counter. It doesn't mean it's necessarily a good idea.
Sure, right. Supplements can have side effects too, and I think that it's easy for all of us to forget that. We know medications, definitely, but it feels like sometimes if you can pick it up in a pharmacy in aisle 7, it is worth trying, and it can have detrimental effects too. So again, be careful what you read out there. I guess is the take home message. But it sounds like that there are some possible upcoming therapies that could be helpful.
Absolutely.
So I'll close with one that I heard of. Have you ever heard of putting a bar of soap under your sheets?
I haven't. Do tell.
Yeah, no, if you Google this on the internet, it's there, and it's mainly for supposedly to help for cramps, either foot cramps or leg cramps, but any kind of discomfort. So, there's the medical explanation for it is really kind of funny, how something in the soap can penetrate the skin, it just falls apart pretty quickly, but it's out there. And I will say, getting a really bad foot cramp in my right foot for, several nights in a row, to where, I had to keep it at a certain angle, and once it went left or right, it would really hurt. The next morning, I did a little Googling, and I read that, and I thought, this is ridiculous. So of course I'm not going to do it. So I did it, so I thought I had a bar of soap, and I thought I'm just going to stick it under my sheets in the morning, and then I'll get into bed at night. I don't know, I thought it had to percolate or,
it has to work its magic. Yeah.
I knew that it wasn't, I knew it made no sense from a scientific standpoint, but, if you're looking at a cost benefit analysis,
right?
It was 59 cents. I had it in the, in my bathroom, new bar, and then again, looking at the possible side effects, unlike a supplement where you really could have some damaging side effects if you took up too much magnesium or something like that. I didn't think I was going to get any negative side effects from a bar of soap. And the funny thing is, at least with the foot cramp, it seemed to help. Now, that annoyed me because I knew that it was a placebo effect, but I also looked up stretches, which in the end is what helped, and that's why I don't have them anymore. But I had to laugh because when you're in a lot of pain, you get desperate and you do silly things. So I guess I share that story because if you are going to try something that's over the counter, I guess the two things I would look at is, one, you really want to make sure there aren't a possibility for side effects. It's not worth trying valerian root or whatever it is, when you're not sure what could happen to you, right? And the second would be cost. There are pills out there. I'm sure you've seen them, Dave. We won't go into them today, that supposedly treat RLS, and you look at the ingredients, and it's a lot of stuff, of the things that we've just talked about, and are expensive, like $40 for 20 pills, and it's a lot of money. So, it's worth thinking about trying some of these, not trying some of these things if they really end up costing you a lot and in the end don't do anything.
Well,
so
I would just say, as I can just, I'll speak for all of your sleep colleagues that work with you. We all appreciate you with using the soap more frequently. So thank you for that.
At the very least, I'm sure it just made my feet smell good. So that was, that's a bonus. But no, I did it laughing and, it helped me at least to, understand, when you're desperate and you need a fix, you try anything. So I will go on record to say I'm not recommending it. And that I had clean sheets, I guess, too. So that was the side benefit. Anyway, in closing, can you think of anything else regarding RLS that you want the public to know today, Dave?
If you think that you're having those symptoms, talk to your doctor about it. I mean, this is a very treatable thing, and you may feel a lot better. It'll improve your quality of life if you get this thing dealt with. So don't be shy about talking to your doctor about it.
Good advice. Okay, let's move on to part 2, sleep apnea. Now, restless leg syndrome might be a syndrome that people might not have heard of. I will bet you most people have heard of sleep apnea. And I think if you line 10 people up and said, do you know anyone or yourself who has sleep apnea or has used, and we'll talk about CPAP therapy, these days you're going to get a lot of people that have.
Oh yeah. Everybody knows, Uncle whoever, has his CPAP machine. He's got his mask, kind of a deal. Everybody knows someone with sleep apnea.
His CPAP machine might be in the closet with an inch of dust on top of it, but we will talk about that in a moment. General overview. What is sleep apnea?
Sure. Yeah. So sleep apnea just means you have pauses in breathing during sleep. That's it. And it comes in different flavors. You can have different reasons for having pauses in your breathing. One reason is if your airway is collapsing and obstructing. So what happens there is your airway kind of partially collapses, as you're asleep, and you're still trying to breathe hard and get the same amount of air. So the air is moving faster through your airway, and that fast-moving air can create turbulence in your airway, and then that makes your airway vibrate, and so then that causes snoring. So you see the person snoring, and then the airway may collapse even more. It may even completely collapse, and so then they go silent, right? You see them trying to breathe, maybe their chest and their belly are trying to move up and down, but you don't hear anything, and that's called an obstructive apnea. You have airway obstruction resulting in a pause in breathing, and then once your airway completely collapses like that, your oxygen level goes down a little bit because you're not breathing in the air, and your CO2 level goes up, which you normally breathe out when your airway is open. Your brain senses those changes and goes, whoa, we need to start breathing again. And so you have a little awakening or arousal. And that's good because then your airway opens up and you start to breathe again, right? You may see the person snort or gasp or wake up kind of like with choking kind of sounds. That's them opening the airway back up and starting to breathe again. So that's good. That's kind of a protective mechanism. But then the problem is that cycle repeats itself. And if that's happening really frequently throughout the night, then you're having all these little arousals. And again, it's one of these disorders where you feel like, man, I got the right amount of sleep last night, but I don't feel like I slept at all the next day. What the heck is going on there? So that would be obstructive sleep apnea. The other kind of flavor of sleep apnea is called central sleep apnea. And all of that means is, again, you have pauses in breathing, but those pauses are not because your airway is collapsing and causing obstruction. It's just a pause in breathing because you're not trying to take a breath. And there can be several different reasons for that, but that's the other flavor. That's less common, but it still happens sometimes. So obstructive sleep apnea and central sleep apnea are kind of the two different flavors of sleep apnea. Obstructive is much, much more common.
And given that, maybe we'll focus on obstructive a little more today, since that's the more common one. What is there a heredity factor? Do you find that it runs in families?
Oh yeah, absolutely. So sleep apnea does tend to run in families, and that probably has to do with the fact that the things that can contribute to sleep apnea, like the structure of your airway. So if you have a larger or smaller airway, if you have a larger or smaller jaw, if you've got a big tongue, all those things are kind of anatomical factors that can contribute to airway obstruction, and so that just your anatomy tends to be similar in families. Just kind of is something that you inherit. And so that's probably why it runs in families. The other thing that can run in families is trouble with weight gain, and that is another big risk factor for obstructive sleep apnea is being overweight or obese. And as you add that extra tissue in your body, you can also get some extra tissue, around your neck, get that big neck, that can also, contribute to airway collapse. And sometimes that fat is also deposited in the tongue, and having a big tongue can also contribute to airway obstruction.
And so, it sounds like that we're going to be kind of going down the road of possibly some lifestyle changes that could help with this. Before that, so unlike RLS, this is definitely something that you wouldn't diagnose just from a questionnaire, because most of the symptoms are happening when you're asleep. So either you wake up after a full night's sleep and you're still tired and don't feel refreshed. Or again, you have that morning coffee conversation where you were snoring all night and, your bed partner is letting you know that. Is snoring, one of the most common symptoms, and is it always a symptom of sleep apnea?
So the most common symptoms in adults, yes, snoring, loud snoring, being fatigued during the day, and being sleepy during the day. But you don't have to have all of those symptoms, or you don't necessarily have to have snoring. Other symptoms that people can sometimes have, sometimes they're very restless sleepers, tossing and turning, and that may be because they're trying to kind of reposition and open up their airway, right? They'll be maybe cranking their neck back, trying to open up their airway. Maybe they're breathing through their mouth. They may have gasping or choking awakenings. And sometimes they have to wake up a lot and go to the bathroom a lot during the course of the night as well, actually. So snoring is very frequently associated with it, but not necessarily, is kind of the short answer. And so to really kind of make the diagnosis, if there is a suspicion for sleep apnea, then the next step would be doing a sleep study, to see if that's actually going on or not.
And, I know from our sleep disorder center, we have a lab. Can adults if you're looking at sleep apnea, can adults do an at-home sleep study? Is that an option?
Yeah, that's a great question. So in kids, me and Kevin, we usually just treat kids, and in kids right now, currently, the standard of care is still you got to come into the sleep lab because that's more accurate. And kids may not have as severe sleep apnea, so we may miss it if we do an at-home sleep study. In adults, that's not the case. If a lot of times, if you're having an adult who's presenting with symptoms concerning for sleep apnea, and you suspect they might have pretty bad sleep apnea, maybe moderate or severe sleep apnea, and they don't have any real other major illnesses or sleep disorders that could sometimes confound the sleep study, then a lot of times you can do an at-home sleep study in the adults, which is, more convenient, and a lot of people prefer that. It's not quite as necessarily as accurate a lot of times, especially for mild obstructive sleep apnea. But for someone who has moderate or severe, it's a reasonable option for them to consider, definitely.
And if you had to do an in-lab sleep study, it isn't the worst thing in the world. When I started in this line of work, I wanted to have one just to be able to talk to patients about what it was like. And, no, I didn't sign up for a multi-pack where, going every month like some sort of timeshare. I don't want to do it again. It wasn't my best night of sleep, but people worry that, they aren't going to pass it or they won't be able to do it. I think with the people who may have sleep apnea, they're pretty darn tired. Usually, not always, but, you'll sleep. It's not, like I said, you have, it's a test. So you have things, hooked up to and everything, but it's not invasive. It doesn't hurt. And it's one night. So it's it's not the worst thing in the world, fortunately.
Exactly. Yeah, I did the same thing when I was a fellow. Right at the beginning of the year, they had us do sleep studies just as, again, experience what you're ordering, kind of a thing. So you know what you're sending people for. And I had the same impression, right? There's nothing natural about the sleep that you're getting in the sleep lab. You got all these stickers and sensors all over you. You got some stranger coming in and out of the room. You got a video camera up in there. I mean, right? It's different. But exactly like you said, almost everybody gets enough sleep to where we're able to kind of answer the question about yes or no, they have sleep apnea, and if so, how bad is it? Which is really why we're ordering the sleep study in this circumstance.
So I think the take-home message is if it's determined that you need one, try not to worry about it. There are many tests out there that you probably have already had in your life that are more invasive or painful. So this is not. So if you need it done, get it done. All right. So you've been diagnosed with sleep apnea. What now? Right. So yeah, let's fix it.
When I think about treatment options for sleep apnea, I think of them kind of like a menu. There's a lot of different therapies out there that we can consider, and what's right for one person might not be right for another. But in adults, usually the first place where we're starting is usually with CPAP. So wearing the mask on the nose at night, and it's a pretty simple idea, right? In obstructive sleep apnea, your airway is collapsing, and what CPAP does is it blows extra air in your airway to keep that airway open. So it's a pretty simple therapy. It's all that machine is doing is it's basically just taking air from the room and it's blowing it in your nose. It's heated, humidified, purified air. It's the best air you'll ever breathe, but it's just air.
And it's air, not oxygen, because that's a confusion. A lot of times people think that it's oxygen that they're breathing, but it's just air.
Exactly. If we're just doing CPAP, it's just taking room air, so air from the room that has the same amount of oxygen that you would normally be breathing. If sometimes we have a patient where they also have other things going on where they may have low oxygen levels in addition to having sleep apnea, where then in that circumstance we would add in supplemental oxygen to their CPAP. But if it's just the CPAP machine, it's just air. There's no supplemental oxygen with it.
So the plus side to CPAP therapy is that it can be pretty darn effective. The downside, bringing in the behavioral component a little bit, is that for many people, it's not easy to get used to. And the most recent numbers I've seen is with adults, 35% really struggle and either wear it less than recommended or it's in the closet with some shoes on top of it, unfortunately.
Yeah, exactly. Right. It works, but you got to wear the darn thing for it to work. And boy, that's a hassle. I mean, you got to do it ideally every night. You got to remember to put the thing on. Sometimes the mask doesn't fit exactly right, or, there's some obstacles that sometimes we have to overcome, but for most people, it's doable. It just it's work. I mean, it takes some work. It takes effort on the patient's part and takes kind of pairing with your sleep team to really make it work the best that it can a lot of the time.
And I think in the pediatric world, it's a pretty straightforward referral to engage someone like me, like a sleep psychologist, to help with that. In the adult world, I don't think that that's always the case, but there are psychologists, other mental health specialists out there who are trained in helping people change habits and make new habits, and it can be really helpful. So some of the adults that I've talked to unfortunately don't get to that point and understandably get frustrated and give up. So if you're listening right now and you're in that category where you were prescribed CPAP and you're really struggling, talk to your referring physician about engaging either a psychologist like myself or a mental health specialist to help with that. There really are some effective behavioral treatments to help make it a little easier. Because the thing about CPAP, it seems, is if you could just get past that hump, and it's a tough one, then you really can start to feel the benefits.
Yes, I'm nodding my head furiously as I'm listening to you say that, Kevin. The other thing that I would add to that is really a lot of patients need to advocate for themselves and kind of also take a really active role in the education about CPAP. And so several of these major companies that produce CPAP have come out with wonderful apps that you can download on your phone. So when you get your CPAP, you get that app on there as well, download it and use it. And it connects right up to your machine, so you can keep track yourself of how often you're using it, what are your leak levels around the mask. And they've also got some really nice educational materials that they've paired with that, both on their websites and on their apps, that can go over a lot of these things and be very helpful for people. The other thing I would say is two things. One, right up front when you're working with the company that actually provides you the CPAP machine, so they're called the DME or Durable Medical Equipment Company. Take time up front to try out different masks and see which one you feel is most comfortable, that you think is the most likely one that you're going to use. You want to start off with a mask that's comfortable rather than struggling with one for weeks or months, and then before you finally switch to something else that's much more comfortable. And then also kind of the squeaky wheel kind of gets the grease there too, for making sure that you're getting the replacement supplies as often as you should, and cleaning your machine like you should be, and all of those kind of maintenance things are really important, and something where as a patient you can kind of take an active role and advocate for yourself and optimize your health, things that you have control over.
Well, this seems like a good time to say this then. One website I would recommend is sleepapnea.org, sleepapnea.org. It is really well done. It's from the American Sleep Apnea Association, and it talks about things like how to reach out for help with the topics that we just discussed. You are definitely not alone in this. So before giving up, which is understandable, make sure you explore all of your options. While we're on that, I'll jump back to RLS real quick because I forgot to say, the website I like for that is rls.org. So they're both .orgs. They're both pretty straightforward names, and both really good. So there's much more information than we can cover today. Those are the websites that I would recommend. So Dave, if CPAP isn't the next step, what are some other therapies out there?
Absolutely. So there are several others to think about. Okay, some of them are lifestyle, and some of them are not. So one thing, of course, that is incredibly hard to do, but is always important, is if someone is overweight or obese, working on fitness and nutrition to get to a more optimal weight that will definitely a lot of times help with severity of sleep apnea. Okay, that's one. Another one is, what are we consuming that could be worsening our sleep apnea? So any sedative type substances or alcohol worsens sleep apnea. And so thinking about that, okay, those are lifestyle things we can think about. A lot of people now are doing dental devices. So adults who have mild to moderate sleep apnea, who can't tolerate CPAP, a reasonable option a lot of times is getting a dental device called a mandibular advancement device. And really all that this is it's a mouthguard-like device that a dentist can make for you, and you just wear it at night, and it basically pushes the lower jaw forward. And when you push that lower jaw forward, it helps bring all the structures in the airway up and out, and helps open up the airway and prevent airway obstruction. So that's something that is a wonderful option for a lot of people. And if they're not going to use their CPAP, it can be very effective as well. I would say if you're considering that therapy, making sure that the dental provider that you're working with has a lot of experience with these devices, because they also can have some side effects. So you want someone on the team who can help you if those things come up. So there's some dental devices. Surgery is an option. So in kids, we're a lot of times talking about tonsils and adenoids, but in adults, there are also some surgeries that could be considered. So for a while, there was a surgery where they would take out different soft tissue areas in the upper airway called the UPPP. That's not as popular there, but for some people are good candidates for that still. There's a larger surgery that actually works on the bone structure. So that surgery is actually where they adjust adjust is a gentle word for it. The jaw, so extending the lower jaw out, especially to help open up the airway. That's called an MMA, and that actually has some fairly decent data. It can be very effective, but that's a surgery. That's a surgery on the bones of your face. Okay.
Sure.
And the kind of the latest and greatest thing that's coming out is something called a hypoglossal nerve stimulator. So all that is where they implant this device that's kind of like a pacemaker-like device, where you turn it on at night, and when you're breathing, this device delivers a gentle pulse of energy to the nerve that serves your tongue. And so when you breathe, it provides a little shock to your tongue, and so your tongue moves forward instead of falling back. And so that can prevent airway obstruction that's happening for that reason. And so that is becoming more and more popular. There's more studies looking at that as a potential therapy. And so there's a lot of options out there surgically. I think that when you're considering surgery, the really important thing is that you are meeting with a surgeon who has a lot of experience with sleep surgery and can help determine which, if any, of these therapies you would actually be a good candidate for. That's really important. And then the other one, which I don't remember if we touched on, was positional therapy. So some people only have sleep apnea really when they're sleeping on their back. And if during their sleep study your sleep physician notices, gosh, when you're on your side or on your belly, you're not having any or hardly any obstruction at all, then there are some positional therapy devices that you could use that basically help you keep off of your back while you're asleep, and sometimes that can be an effective therapy as well. So there's a lot of things to consider, a lot of different types of therapies to consider, and really it's, okay, what's right for this particular person.
Now with that positional therapy, I tested one where it looks like a big reverse fanny pack. So
Yes.
It's a belt, and then it has, instead of the pack in the front, it's on your back, and it's big, and it's soft, but solid enough that if the idea is that if you start to roll on your back, you can't, and it hopefully doesn't wake you up. It just kind of forces you to get back on your side or your stomach. And then, and you know, that it's not cheap. You can make one, if you're crafty or know someone who is. You can get a t-shirt and sew in a long vertical pocket in the back of the t-shirt, and then just put tennis balls back there. And, you know, so that's cheap. And then it serves the same purpose. If you start to roll on your back, it's uncomfortable. And then what you have to see is hopefully it's not waking you up. Then that would not be helpful, but, it's just enough to where you go back to the position that you were in. So.
Absolutely. Yep. And I've done that with some of my patients as well. Exactly what you're describing.
Yeah. And then, so it sounds like the take home message is, if you're getting an adequate amount of sleep and you're still tired and you fit some of the symptoms that we're talking about today, like snoring and things like that. Dave, would you add a dry mouth can be for some people with sleep apnea because their mouth is open?
Yeah, sure. If their mouth breathing all right, then you can get a dry mouth. Absolutely.
Or even headaches in the morning. Is that another one that might
of course.
for some?
Yep.
Yeah. So if you have some of these symptoms, it's easier to identify them if you have a bed partner. But if you don't, you know, if you're sleeping an adequate amount and are still tired, in general, that is enough of a reason to talk with your physician. You know, sleep, unfortunately, in our society doesn't always float to the top of importance because we're busy and we're plugged in and we have social media and all that. And, it's also kind of a badge of honor sometimes that, I don't need a lot of sleep, or I always think that's interesting because we would never say, I don't need much oxygen or I don't have to drink water, you know, I mean, and it's right up there. So, part of my goal here is to advocate for sleep. I know I'm biased and so are you, Dave. We think it's pretty darn important, but it is, and it can affect so many aspects of your life. In fact, I challenge people to think about one where sleep doesn't affect it, whether it's mood or job performance, school performance, general health. So if you're tired and you're not sure why, talk to your doctor. Get the ball rolling. It's important. Don't feel like going to the doctor just because you're tired isn't worth it. It absolutely is. Anything else you want to add, Dave?
I would just echo what you just said. I mean, sleep is a bodily function. It's a basic bodily function that affects, every aspect of your life that we look at. I mean, but the most important one is just how you feel during the day. And that's why this is such a great field to be in, because when we can help people with their sleep problems, man, a lot of times they are very appreciative because they can feel the difference a lot of times pretty quick, and it's not, which kind of makes it different than, okay, we got your cholesterol better, we got your blood pressure under better control. No, we treated your sleep apnea and now you're able to stay awake during the day or concentrate better or your mood's better. So it's really a wonderful field.
Well, and it's fun and interesting because and we just hit two issues, regarding sleep today, right? But it's also a family issue as well. So, if you're a parent, you're a better parent when you sleep better. If you're a better friend when you sleep better, you're a better partner when you sleep better. So your sleep, affects your family as well. So, it can have, a positive effect beyond your personal health too. So, yay sleep. All right. So Dave, I want to thank you so much for joining me today. So informative and interesting. I truly appreciate your time and thank you for doing this.
My pleasure.
All right. And thank you all for listening. Sleep well.